Our next speaker is Dr. Soon. He's the Associate Professor and Assistant Director of Research at the Department of Neurosurgery at RWJ and is an Associate Program Director of the Neurosurgery Residency here. He also serves as Vice Chair of Clinical Affairs and Chief of Neurosurgery Services. Dr. Soon is a favorite, especially among his M2 students in his research lab, who say he has been an extremely supportive PI and mentor to all of us in his lab and goes out of his way to ensure we have the tools we need to succeed. He is truly an inspiration and joy to be around. So here's Dr. Soon with his talk named Lessons Learned While Practicing Medicine.
First of all, thank you for inviting me to be at this event. I'm honored to be among the peers who had a lot of wisdoms about their journey through medicine. I also don't have any slides, and I think you probably start to see this theme emerge from a lot of the talks people give is their reflection on their interaction with others in medicine. And I think that's probably what I cherish most about my profession. I think as a surgeon, like Dr. G was talking about, we all have moments that we doubt our abilities and we feel impotent at the moments that, for example, we have patients have cancers we don't have surgical option for. And I have had surgical complications that will keep me up at night for a long, long time. And I have people ask me, how do you deal with a situation like that? When the moment like that, I start to think about my journey through medicine, and there are a few moments that kind of stopped me on the track that had taught me a lot about this profession. I have 3 stories I want to share with you, and hopefully that will help you see where I gained the strength and the strategy to face those challenges. I think the bottom line is I think we have to keep those moments close to us that we never get used to, that, those just part of our profession. I think those difficult moments, for me personally, it always will be difficult. And I don't want that to go away, because I think I owe it to this profession, I owe it to my patient to feel the difficulty of those moments. So the first story I want to share with you is during my first year as a medical student, we had a course called Undoctoring, which probably you have. It's kind of the course you start learning how to interview the patient and learning those basic skills. And I think maybe even like a first couple of classes, maybe the first one, the preceptor asked us questions. So if you have a choice, you can make how you want to die. There's 2 choices. One is you die suddenly. Let's say you a terrible car accident, you died, just vanished. Probably not much suffering. Or you die in a long, extended disease where you suffered quite a bit. So I think a lot of my classmates immediately thought, I want to die quickly. I don't want to suffer. But then I think the preceptor said one of the advantage of knowing when you may die and you have time is you have time to say goodbye to your loved ones, which you may not have if you die suddenly. So I think maybe a couple weeks after I had this encounter, I went to shadow a family internal medicine doctor. He went to see a patient who is, I think, 95 years old, living in a retirement community. And he had a pneumonia. But because he had a long history of heart disease, the pneumonia is setting in, and he is going to heart failure. And he looks well, but my doctor was telling him, in order to save you, you probably have to go through intubation and all those things. Or we don't do that because he already had an advance directive that he doesn't want to go through that. He had his wife and the daughter at the bedside. They actually was planning on a trip to the Cape Cod the next week. But because of this onset of this pneumonia, they couldn't make to the Cape Cod, and they realized that this is the moment to say goodbye. And he looked to us, smiled a little bit, and turned to his wife, just said, I guess this is it. I think there was not a dry eye in that room at that moment. So reflecting that, I began to realize dying is never going to be easy, no matter what kind of situation you're in. This gentleman had a full life. He was playing tennis a week ago. If I had known that's how I would die, I would say, I definitely would choose that. I was successful. I did everything I can. But then I realized if you live like that, you want to live more. Why do I have to die? I have everything I want. I want to keep going. I want to go to Cape Cod. So that's how I learned is that those moments never going to be easy. Either you had a patient with a 40-year-old with glioblastoma you couldn't help, or you have a 95-year-old fell at home, had a large subdural, probably doing surgery, it's not going to help. They're going to succumb to the disease. It's never going to be easy. So those moments are important to our patient, their loved ones. I think it's a privilege that a lot of us get involved in those moments. I truly feel those are it's an honor to be involved in those process. And a cliche, one of my mentors always tell me is like, I can't believe people pay us to do this. And I do feel that. It's because those moments. The second encounter is, I think I was third year in my surgery rotation. Our hospital had a VA, and I was going to work go to a clinic to work with the chief of the surgery at the VA, who is a thoracic surgeon. Very, well respected. So I was a little nervous going to be in his clinic. I was afraid he was going to ask the questions I wouldn't know. And so the first patient we were about to see was a 68-year-old gentleman living in rural New Hampshire, and was, I think, a Vietnam veteran, and came in. My surgeon had performed a lumpectomy for lung cancer. Successful, has been following with him for several years, but he just had a CT scan. Cancer came back, widely metastatic, no surgical option. So he has to tell him that. So when the gentleman came in, Dr. Nugent just sat him down, and he sat next to him, same level, eye to eye. He asked him, I forgot the gentleman's name, maybe Bill or something. How are you doing? What do you do for fun these days? Are you still fishing? And at that moment, I just felt that was the thing perhaps that patient cares the most about. And that eased a lot of tension in the room and made the patient comfortable. And also, I saw a model in Dr. Nugent who treated his patient as almost a partner, family member, was able to develop that kind of rapport with him and truly care about how the patient is living, how they deal with their illness, how the illness affects them, what kind of things they can or cannot do. And I think the patients see that in their doctor. And then they earn the trust. And to me, I think, we always say as a surgeon, your patient only see the incision. So what you do inside the body probably doesn't matter as much when you close the incision. You really have to be careful because that's what the patient see. And I also, in that moment, I also see probably patient care more about how we view them as an individual. And not necessarily whether we will be able to cure them or not. Because there will be diseases, there are diseases that are out there we cannot cure. There's just not enough medicine, not enough technology that we can offer to those patients. In those moments, I think your care, your ability to relate to them, to understand the struggle they are going through, I think it will mean tremendously to them. And also, I think those human interactions, it's what I view it's the most rewarding part of what I do, even though, as a surgeon, we work hard in the OR and doing things. But to be able to be part of their life and to maybe offer them some comfort in their fight for their illness, I think it's very rewarding. The last story I will share, it's actually just happened maybe 3 weeks ago. So I'm an epilepsy surgeon. I treat patients with epilepsy. And one of my patients I did the surgery on is a 35-year-old lady with Lennox-Gastaut syndrome. So those are the generalized seizures caused by genetic conditions. So those patients, they have developmental delays because they have very early onset of epilepsy. They probably start seizing when they are just less than 1 year old. So they have seized the entire life. And we don't really have a good treatment for. The surgical procedure we offer to this young lady, is colostomy, which basically we disconnect the right side of the brain with the left side of the brain. Because this is a generalized epilepsy, so when the epilepsy happens, the seizure just spread through the entire brain. And for a lot of pathophysiology we don't quite understand, but we have some understanding, is in those situations, if you cut the connection of the right side of the brain with the left side, the seizure frequency decreases. Their quality of life improves. And also this is very effective for the type of seizure called an atonic seizure. When the patient have seizures, they lose muscle tone, they fall down. So they injure themselves. On top of the having seizure, they also have the physical injuries from this. And the colostomy was very effective for this. So for this lady, when we were talking to her, about her in the epilepsy conference, we have epileptologists, the neuroimaging experts. It's a conference where all of us will have to agree on a procedure that's safe and effective for the patient. So we decided that the colostomy, because she has never walked in her life, and also she doesn't talk because of the burden of a seizure was too high. And the colostomy, for some people with higher ability, for example, if they walk, they talk, they can wind up with a condition called disconnection syndrome, where they can't walk anymore and lose ability to talk. So the risk for the colostomy was low, and the benefit was high. So we decided to do this. But because of the risk was low, so I was very comfortable with this procedure. It was very successful. We did it use a new technology called the laser ablation. So we don't even open the skull. We use a minimum approach to insert a laser probe, then deliver the heat to the intended areas. Then we use MRI to monitor where the heat goes, so we can deliver the heat to exactly where we wanted to do. And the surgery went very well. But it was a long procedure because of setting up, doing it in the intraoperative MRI and all that. So I came out to talk to the patient's mother. She was so worried. I can just tell. When I walk out to the surgical waiting area, she was not comfortable. When she saw me, she immediately stood up and come to me. She also was Spanish speaking, so I had to get a translator. I told her, I said, everything went well. She did very, very well. And after she heard that, she had tears just pouring out of her eyes. So at that moment, I realized she was so worried. Her daughter means so much to her. Even though she didn't walk, didn't talk, very disabled. But she probably treated this child just like her other daughter or son. There's other family member like that. It probably meant a whole world for her. And I had tears in my eyes because that was just so moving to me. And also reflecting on that, we thought perhaps what we do is improve her quality of life somewhat, but we also thought maybe her quality of life wasn't that great. But to her mother, this is such important thing to her, and it was so moving to me. And I see maybe that's a lot of mothers feel with their children. And it's the moment like that, caught me unexpectedly. And that's why I feel what I do is tremendously rewarding. And it's also because of those emotional engagement with the patient that I cherish. And I think that's also what we need to hold on to while we practice medicine. When I have complications, I will always feel terrible, always. I will never let that edge become dull, because I don't think we will ever should do that, because what we do to our patient and their loved one is so important to them. And we really should always be ready to feel those intense emotions, whether it's exhilaration or disappointment. Thank you very much.